సో అందుకని హై ప్రెషర్ లో ఎయిర్ వచ్చారు. నాకు మొన్న ప్రాక్టికల్ గా వీళ్ళు చెప్పిన కాంప్లికేషన్ కి ఇది చదువుతున్నప్పుడు నాకు అర్థమైంది. సో విచ్ ఇస్ వై ఈజ్ ఆస్కింగ్ నాట్ టు సక్షన్ ద GRV బట్ టు through a syringe తీయమని. సో లాట్స్ ఆఫ్ లెర్నింగ్. ఈవెన్ చాలాసార్లు మనం బేసిక్ టాపిక్ అనుకుంటాం కానీ అంటే ఈ దట్ క్యాలిక్యులేషన్స్ ఆఫ్ ప్రోటీన్ నీడ్స్, ఎనర్జీ నీడ్స్ అండ్ డిసీజ్ స్పెసిఫిక్ అదంతా కాంప్లికేటెడ్ స్టఫ్ కానీ మోస్ట్ ఆఫ్ ద టైమ్ వీ డూ బేసిక్ మిస్టేక్స్ ఎక్కువ చేస్తాం సార్ మనం అండ్ మన స్టాఫ్.
స్టార్ట్ చేద్దామా?
స్లైడ్స్ మూవ్ అవుతున్నాయి కదా సార్?
మూవ్ అవుతున్నాయి.
థ్యాంక్స్.
స్లో జాయిన్ అవుతారులే, ఇంకా తెలుసు కదా. స్టార్ట్. గుడ్ మార్నింగ్ ఆల్ ఆఫ్ యూ. Due to some reasons, Thursday class has been postponed to today. Dr. Srikanth is going to talk on enteral nutrition, few questions and few guidelines. Even though it is a very well known topic, but there are so many doubts, so many issues are there, because as we usually we don't bother and we don't concentrate on feeding in ICU, which is very important and it plays a major role in the patient outcome in critically ill patients. I think Dr. Srikanth is going to enlighten on this and he will answer our questions also. Thank you, Srikanth. You start your presentation.
Thank you so much, sir, for the kind introduction. First of all, sorry I couldn't make it on Thursday due to a family event. When we talk about enteral nutrition, one of the most common practices, what we do in our day-to-day ICU. So we may say we know most of the things, most of the stuff and all, but to quote an analogy, and when I ask my first standard daughter to recite a 2 table, she will say it's very easy. The kids have a way of saying easy peasy lemon squeezy, but again she will miss somewhere. So that's what we do regularly with our routine practices also. Take it for the CVP bundle or an endotracheal intubation or a maintenance of lines and all. Even though all these are the things we the stuff we do routinely, but again when we properly learn a few practice guidelines and their application in a practical scenario, we come across some of the common mistakes we encounter, we do, and our staff do due to lack of proper training. So this, so see, food is energy. We all know that our grandparents and parents used to tell us. So whatever food we take, be it carbohydrates, fats, proteins, everything. So all the stuff you take will actually metabolize by a common pathway of ultimately it gets oxidized. So it gets oxidized to carbon dioxide and water, and the heat, the chemical energy is released after the food metabolism. So that chemical energy, the body, to maintain isothermic, it has to transfer. So the energy can neither be created nor destroyed. It can be just transferred between different mediums. So some of the chemical energy is lost in heat, and the remaining is stored in powerhouses of our body. The most important one is ATP, adenosine triphosphate. So from there, the energy is utilized for biosynthesis, osmotic shifts in the body, and physical activity. So the energy expenditure can be broadly divided into resting energy expenditure, which is important to carry out the day-to-day activities, and the diet-induced thermogenesis, which is used for metabolism of the food. And also the third one is for physical activity, when you do a strenuous exercise or any unaccustomed work. So this is the basis, and this is one of the principles for calculating the energy requirements through the indirect calorimetry in centers where it is available. So we are not going into much details because this is a very complicated or an extensive topic, and it takes around 3 to 4 hours of continuous lecture to deliver the complete stuff of this. But we are today, in this 30 to 40 minutes, we are just going to deal with the more practical issues and a few guidelines which are published by our ISCCM. So there are ASPEN guidelines, which is the American Society of Parental and Enteral Nutrition, BAPEN, British Association of Parental and Enteral Nutrition, also UPEN, which is the European, and this is our Indian guidelines, which were published in ICCM Journal in April 2018. These are based on the 2016 ASPEN guidelines. So from there, last year 2022, there is an update in ASPEN guidelines, but that is just related to 5 points in the 2016 guidelines, which we'll be dealing at the end of the class. So we are predominantly going to find out what our ISCCM have to say for nutrition critical ill patients, especially for an Indian scenario. So most of this stuff you must be knowing why we actually need to feed the patient early due to the early catabolic response to critical illness and trauma. The glycogenolysis, gluconeogenesis, all contributing to hyperglycemia, and there is protein loss, muscle wasting, and all. So which is the need for more aggressive feeding, and always, as you know, enteral route is more preferred than parenteral nutrition wherever feasible. So when we talk about evidence in these practice guidelines, this is the grading of the evidence. So 1 being the highest and 6 being the weak, and strength of recommendation, A being strongest and C being weak. So initially, general guidelines, coming to general guidance, all the critically ill patients should undergo nutrition assessment on admission. Observation of signs of malnutrition should be done. Cachexia, edema, muscle atrophy, BMI less than 20 is critical. Enteral nutrition should be started early, preferably within first 24 to 48 hours, unless there are absolute contraindication like some gastrointestinal disorder or a completely hemodynamically unstable patient. So in case the nutrition requirement is not met adequately with enteral nutrition, even after 7 days of ICU admission, then usage of parenteral nutrition may be considered, that too after 7 days of ICU admission. So nutritional support should be considered as of therapeutic benefits and not just supportive or adjunctive. So this carries a very important role, because most of the times when it comes to the practical application of feeding, so this nutritional support always we have to be when we are talking about the routine nutritional enteral nutrition practices in our ICUs, we have to be brutally honest with ourselves. So always the nutritional support takes a back step when compared to active medical management, antibiotic, ventilation therapy, and all. But this is to be considered as a medical treatment and not just a supportive treatment. In the British guidelines and American guidelines, they have added ethical and legal considerations of enteral feeding also in the guidelines, but in our ISCCM, it's not included. But recently in our ICU, we have faced an issue like the patient denied enteral feeding. So this is the first time I remember in these 8-9 years when a patient, particularly when we spoke to the patient that we are starting him on enteral feeding, they actually denied enteral feeding. So because of some apprehensions they're having, some tubes inside the body of the patient, we try to explain in every sort of way that it's not going to help the patient and it can be detrimental, but they bluntly denied. And then we have got a written informed consent saying the quoting the same in the case sheet. So this is how it can sometimes turn be, and these American guidelines and British guidelines say it should be treated as a medical treatment and not just a supportive or urgent. And this is what our Indian guidelines also say, but in a more like a secondary conclusion sort of way. But we have to get proper consent, especially at least when they are rejecting, and also it emphasizes the need for a critical care physician to inform the patient attendants that we are starting something or putting him on something. So electrolytes should be strictly monitored in patients on nutrition therapy, assessment of drug nutrient interaction to be done on daily basis, which is again, as you can see, some are moderate quality B5 like that, because as these guidelines are based on an Indian scenario, so the daily assessment of drug nutrient interaction generally takes a backseat in most of our ICUs. So the tube feeding should be considered if even 50 to 60% of nutrition targets are not met adequately within 72 hours of oral nutrition support. So if the patient is not taking adequately and hardly a 50% of nutrition target is reached with the oral feeding, then you have to consider putting him on a Riles tube, or in case of a long-term feeding, if you assess initially, he can be placed for a PEG tube or a jejunal surgical gastrostomies and jejunostomies. And also in case of obstructive pathology, straight away, if you have the diagnosis, you can go for surgical techniques of jejunostomy and gastrostomy. So then we come across, we have decided to place a Riles tube, start an enteral nutrition. What about the hemodynamically unstable patient? What the guidelines say? So clinical monitoring of gut function should be started early when the patient is hemodynamically stable. Once the patient has been fluid resuscitated and stabilized on declining doses of less than 2 vasopressors, then it can be started enteral nutrition. Otherwise, in a very unstable hemodynamic patient, enteral nutrition should be at least temporarily withheld. So when once the initial fluid resuscitation is done, it's somehow stabilized, partially stabilized, and the dose of vasopressors are coming down, then you can start with a low dose of enteral nutrition. So it should be administered ideal once the patient is stable with vasopressors. It should be administered within 24 to 48 hours. So in persistent shock, early enteral nutrition should be avoided. So these are all very strong recommendations. So coming to nutritional screening and assessment. So the nutrition which we actually do most of the time clinically, and this part is I think it's a very weak when we do for a routine nutrition screening and assessment. So then actually coming to the Aspen guidelines, they recommended nutrition assessment tool 2002 NRS, and also the Nutrix score. But in ICCM guidelines, we have an for Indian set of population, we have a easy bedside doable assessment tool called SGA. And initial monitoring of nutrition intervention must be done on daily basis, and nutrition plans should be modified accordingly. So it is imperative that nutritional assessment is done by well qualified and trained nutritionists. Again, this area we are lacking. So most of the ICUs don't have a trained nutritionists or dedicated dietitians involving in the treatment diet plans and all dedicated to the ICU. So it's desirable that nutritionist wherever is available to critically ill patient ratio should be maintained at 1:25. And wherever feasible, computerized tomography or cross-sectional imaging or ultrasound can be used to assess the lean muscle mass. The facilitation of nutrition assessment will require good coordination between the intensivist and nutritionist if at all they are available. So I think it's not so clear that this is the SGA tool what we are talking about, subjective global assessment form. It takes into consideration the recent weight loss and changes in weight, dietary intake, and any like gastrointestinal symptoms, functional capacities, and all. And also, it includes the physical examination, assessment of the subcutaneous fat under the eye, triceps, biceps, everything, and looking for the signs of muscle wasting, and each is given a grading. So this is the NRS, what we are talking about in the Aspen guidelines, nutritional risk screening. So it takes into consideration impaired nutritional status with BMI, food intake, and weight loss, and severity of the disease as mild, moderate, severe, and age. So based on that, the score, we will assess the nutritional status of the patient on admission. This is the Nutric score. We are talking about two slides, and this variables like age, Apache 2, SOFA score, number of comorbidities, days from hospital to ICU admission, IL-6 levels, it takes into consideration, and based on the score, 6 to 10 is considered as high score, and 0 to 5 is considered as low score. So estimating the energy protein requirements here. So feeding should be tailored as per the patient's requirement and level of tolerance. Protein requirement for most of the critically ill patients is in the range of 1.2 to 2 gram per day per kg body weight per day. So calories should be generally in the range of 25 to 30 kilocalories per kg body weight per day for most critically ill patients. So these two are the most standard and strongly recommended guidelines by the ISCCM. So in severely hypercatabolic patients such as extensive burns and polytrauma, the ratio of kilocalorie to nitrogen should be 120 is to 1 or even 100 is to 1 has been accepted. Again, the protein intake in burns and all, they have Toronto formula and all, where they take into consideration the percentage of body surface area and also time, number of days since the burns. So all those you can search in Google, and I will be sharing all the relevant articles after the class. So for obese patients, again, adjustment in calorie and proteins must be done on the basis of body weight and BMI. Toronto formula is used for energy requirements in severe burn injury. And Harris-Benedict tool may not be suitable because the equations in this method are too long and time consuming and overestimate the energy requirements. So this is the recommended PM requirements in the intensive care unit based on the various guidelines they have formulated. So at the end of the day, you have to individualize for the patient. Generally, you can go with 25 to 30 kilocalorie per kg. So in acute phase, you can start low with 20 to 25, and recovery phase, you can go up to 25 to 30. And protein also, it's the same 1.2 to 2 gram per of protein per kg based on the BMI. If the BMI is 30 to 40, it's 2 gram per kg. If the BMI is more, you can go for 2.5 gram. Again, for obese patients, they have recommendations. So based on the Aspen guidelines, so the energy intake should be either 11 to 14 kilocalories per kg actual body weight per day for patients with BMI in the range of 30 to 50. If the BMI is more than 50, you have to go for ideal body weight and not actual body weight. In that scenario, 20 to 25 kilocalories per kg, ideal body weight. It's the same with protein too. If it is so 2 grams per kg for ideal body weight for BMI 30 to 40. If it is more than 40, it is 2.5 gram per kg. Here you have to, when you're feeding proteins, you have to take ideal body weight into consideration for both the BMIs. Whereas when you're calculating energy in the 30 to 50 BMI range, you have to take the actual body weight and a low kilocalorie per kg. So hope it's not so confusing. Okay, coming to the route of nutrition. So enteral nutrition should be considered over parental nutrition. And when we are talking about a combination of enteral and parental, it should not be routinely recommended except for specific indications. So in critically ill patients, a supplemental parental nutrition at the end of first week of ICU admission is advisable when the full enteral nutrition support is not possible or fails to deliver the calorie targets up to 60%. So coming to tube feeding, always nasogastric tube should be the first choice of enteral feeding. Jejunal route can be used if required, and specific conditions what we discussed like obstructive and all, they may need surgical gastrostomies and jejunostomies, or long-term feeding may require peg tubes we are using now, or the peg tube with a jejunostomy extension, peg J. All these can be used for a long-term feeding, and they have their own set of complications and mechanical things with both the distal feeding access procedures. So again, the continuous formula feeding with pumps or gravity bags can be preferably done via the fine bore tubes. So tube feeding and nosocomial infection. When we are talking about any feed if you are giving through a tube, the two most important things are the nutrient content of the feed you are giving and the bacterial contamination. These two things you have to keep in mind. So the scientific formula feed should be preferred over blenderized feeds to minimize the feed contamination. So a blenderized feed or a homemade feed obviously carry more um, like infectious complication because the source of preparation cannot be traced sometimes when they're preparing something and at home and bringing to our ICU. So even in our ICU, we allow this homemade RT feeds and all. So now we are actually gradually planning to shift to a complete RTH commercial scientific formula. So hopefully we see a positive change in the infection rate in our IC soon. So again, even for a blenderized feed, because when you're going it has to pass through a tube, it has to be made into a liquid, any solid or semi-solid food too. When you are blenderizing, again, the blenderized foods, the source, the kitchen personnel, the hygiene they're carrying, and again the carriage of that food from the place of preparation to the hospital and the ICU. At any point of time, it can get contaminated. So whenever feasible, closed system ready to hang formula feed should be preferred. Blenderized formula are more likely to have bacterial contamination than other hospital prepared diets. Hygienic methods of food preparation, feed preparation, storage, and handling of both formula feeds and blenderized feeds are necessary. So coming to permissible underfeeding, again, intentional underfeeding is quite more common, as our David sir was also pointing out at the beginning of the class. So even forget about what we are writing on paper prescription is an underfeeding. Even what we are writing may also not be fully delivered by the nurses to the patient. So sometimes they may miss the dose and sometimes they may miss the volume and all. There can be spillages and all. So according to the estimate, it's hardly like 60 to 70% of what you write is getting delivered to the patient. And also the physician is also a culprit for most of them. So the intentional underfeeding can be restricted to only specific indication, which is a very strong recommendation again, and obese patients can be subjected to underfeeding. So we'll talk a bit more about this underfeeding issue, which this is quite common. So in critically ill patient, underfeeding is generally not recommended. However, patients having feeding intolerance may be underfed. So we'll be talking a bit more in a good slide about feeding intolerance and GRV later. So furthermore, intentional underfeeding of obese patients with a BMI more than 30. In this population, it can add some benefit to the metabolic outcomes underfeeding and decrease in the length of the ICU stay. Hypocaloric enteric feeding in obese surgical patients was associated with shorter length of ICU stay, improved nitrogen balance, and reduced use of antibiotics, according to some studies. So in patients with ARDS or ALI, or those expected to have duration of mechanical ventilation more than 72 hours, either trophic or full feeding is appropriate. Again, when we are talking about trophic feeding, the trophic feeding means so a low dose of enteral nutrition at hardly 10 to 20 ml per hour. So that when we are scaling on a second hourly, it comes to 20 to 40 ml, which is well below the traditional enteral feeding dose what we are giving. So under prescription by physicians is another problem compared to the desire is one of the main reasons for underfeeding. And the relationship between hypocaloric intake and reduced mortality infections and nosocomial bacteria has been found in some studies, but we have to restrict, as the guidelines suggest, of this hypocaloric intake to special group of population and not everyone. So monitoring tolerance and adequacy is the most controversial or the least practiced thing in our is the GRV. So gastric residual volume should be measured by syringe aspiration and not by suction pump. So this is what we are talking before the class. So recently when we had a patient with around 400 ml of GRV, so as most of the guidelines say, if it is only more than 500, we have to withhold the enteral feeding. If it is in the segment of 200 to 500, we have to return 200 ml of feed back to the patient and discard the remaining and decrease the enteral feeding. And we have to look for the signs of feed intolerance and all. But when I was at home when this happened, and they called me saying that GRV came, we have aspirated after 4 hours. So the feed came, gastric residual volume, the aspirate was 400 ml, sir. So I told them, okay, return 200 ml and discard the 200 ml. So to be fair enough, first they thought I'm joking. Then I told them, no, I'm serious. You do the thing. So then after 5 minutes of intense discussion among all the staff nurses, they again called me and they told that, sir, the entire feed what you're talking to return is like in the form of bubbles, foam like thing. How can we return that? So the problem is we are aspirating, or at least in our center, the nurses are aspirating with a suction pump and not through syringe. And the guidelines strongly recommend to aspirate the gastric residual volume by a syringe aspiration and not by suction. So this is a practical problem we faced in our ICU. So gastric residual volume of less than 300 ml can be refed if it is not blood stained, but most of the American and British guidelines, they say 200 ml to be refed and the remaining to be discarded. So holding EN for GRVs less than 500 ml in the absence of other signs of intolerance should be avoided. And the medium range of 300 to 500 ml should be considered in Indian ICUs. Again, this 500 ml is the cutoff range for the Aspen and WAPN guidelines. Again, when it comes to ISCM guidelines, we have a lot of difference of opinion among the critical care physicians and the gastro consultants and the other consultants who are treating the patient according to this one. So the cutoff range has been made to 300 ml to 500 ml, or more frankly 300 ml in place of 500 ml for the Indian scenarios. So it came to a weak recommendation. As you can see, it is C, not A or B. So in case of high GRVs, efforts should be made to continue feeding with reduced volumes. So that's the first step you're going to take. So in case of high output Riles tube, you don't just stop it. You can make an effort to make it a trophic feed or with a reduced volume, like what we are talking, 10 to 20 ml per hour. And prokinetic agents such as metoclopramide and erythromycin can be recommended in patients with intolerance and risk of aspiration. Nurses should be trained properly for monitoring the tolerance. So this is a feeding intolerance score which I came across when I'm searching for a latest updated guidelines in European and American. In that same PDF or whatever, this feeding intolerance score is given. So where they take into consideration, I found it very useful for a practical application, so hence included. So I'm not sure if it is so validated and all. So abdominal distension and pain is one parameter, nausea, vomiting is one parameter, and diarrhea is the third parameter. So there are scores of 0, 1, 2, and 5. And there are points, and he clearly states based on the points, the mortality rate and what you have to do. If it is 0 to 2 points, you continue the EN, increase or maintain initial speed, and symptomatic treatment. Identify the cause and prokinetic. So if it is 3 to 4 points, continue in, slow down the speed, reevaluate the EN tolerance after 2 hours. If it is more than 5 points, suspend the EN, reevaluate or replace the infusion route. You can switch to parenteral if you cannot correct the cause for feeding intolerance. Again, the mortality also based on the score. If it is high score, the mortality of the 28-day mortality is high in case of high feeding intolerance. Selection of appropriate enteral formula. When we are talking about an enteral formula, again, there are three types of enteral formula which we'll be talking in the following slides. So the standard polymeric formula is what we routinely use. Feed should be recommended in the critically ill patients. Inconsistent in neutral level can be avoided by using the standard polymeric formula instead of blenderized and homemade preparation. Routine use of specialty formula feed should be avoided. I mean, like a nephro, HPRLP, or for ARDS and traumatic brain injury, we alter the dose and the composition. The routine used of a specialty formula feed should be avoided, and the polymeric formula should be used in the routine. So these are just a brief note of polymeric feeds. So these contain nitrogen as the whole protein. The carbohydrate source is partly hydrolyzed starch. When if you are going to calculate the nitrogen as the intake, so each 1 gram of nitrogen equivalents to 6.25 grams of protein. So based on that, you can calculate the nitrogen requirement. So the carbohydrate source is partially hydrolyzed starch and the fat contains the LCTs. Their content of fiber is very variable, and although most authorities recommend that fiber should be included, the evidence that higher levels are of real benefit is not that strong. So pre-digested feeds. So this is the second type of feeds. So where in specific scenarios like pancreatic disorders or bowel disorders, where there are disorders of digestion and absorption, these feeds contain nitrogen as either short peptides or in the case of elemental diets as free amino acids. We have even commercial preparations like Ensure peptide and all, where they don't contain the whole protein and they contain these short peptides for a specific group of population. And carbohydrates provide much of the energy content, with the content variable in both quantity and the proportion provided as long chain triglycerides and the medium chain triglycerides. So the aim of pre-digested diets is to improve the nutrient absorption in the presence of significant malabsorption. Their importance is probably greater in maldigestive, as, for example, pancreatic disease, which we're talking about, rather than malabsorptive states. And in patients with a short gut and no colon, their high osmolality can cause excess movement of water into the gut and hence high stromal losses. So again, disease specific, we'll be talking in subsequent 3 to 4 slides. When it comes to pharmaconutrient feeds, again, glutamine, arginine, nucleotides, omega-3 fatty acids, antioxidants, these all come under pharmaconutrient feeds. So again, their protein feeding is not, and most of the polymeric feeds contain adequate amount of all these things. Unless you have a specific requirements, you don't infuse in general as a separate supplement of nutrients. So coming to enteral feeding and diarrhea, so EN should not be interrupted in the event of diarrhea, which is again a strong recommendation. Feeds can be continued while evaluating the etiology of diarrhea. Use of a soluble fiber containing formula or small peptide semi-elemental formula in divided doses over 24 hours may benefit to patients with persistent diarrhea. So before doing that, you have to exclude hyperosmolar agent intake and Clostridium difficile infection. Routine use of probiotics is not recommended, and they should be used for selective medical and surgical population. So coming to importance of micronutrients, again, pre-existing micronutrient deficiency should be evaluated and assessed. Patients on formula feeds may not require additional micronutrients, which you're talking about 2 slides back, vitamins and trace elements, if they are on complete and balanced formula feeds. Micronutrients can be supplemented in patients, especially on blenderized feeds, where we exactly don't know the content of micronutrients and antioxidants, and those on parenteral nutrition. In these cases, micronutrients should be supplemented. So again, coming to immune enhancing enteral nutrition should not be used routinely. Again, in very severe illness where they are not able to tolerate hardly more than 700 ml per day, these should not be used. So these should be considered in TBI patients and perioperative patients in the surgical ICU. And glutamine, again, which is an immunonutrient, is not recommended in patients with multiple organ failure. So, coming to a few disease-specific nutritional therapies, enteral nutrition should be preferred in patients with acute or chronic liver disease admitted to ICU, which is a strong recommendation. No beneficial effects of branched chain amino acid formulation in critically ill patients with encephalopathy who are receiving the first line luminal antibiotics. Protein supplementation is recommended in liver failure, and protein energy determination should be based on dry body weight or usual weight instead of the actual weight. So protein restriction should be avoided in refractory encephalopathy. A whole protein formula providing 35 to 40 kilocalories per kg body weight of energy intake and 1.2 to 1.5 kg per gram per kg body weight of protein is recommended. So tailor sodium restriction to absolute need and on a patient to patient basis. So coming to TBI, initiation of early enteral nutrition of post-trauma period, once the patient is hemodynamically stable, is recommended. Protein recommendations should be in the range of 1.5 to 2.5. It's a bit higher in traumatic brain injury, the protein intake. Arginine containing immunomodulating formulations or icosapentaenoic acid or docosahexaenoic acid supplement with standard enteral formula in TBI patient is recommended. So in these type of patients, the role of immunonutrients come into place. So in coming to the respiratory compromised population, calorie dense enteral nutrition formulation should be recommended for the patients with acute renal failure. ARF here refers to acute respiratory failure, sorry, especially if in the state of volume overload. Small frequent feeds should be preferred to improve the nutritional compliance. Monitoring of serum phosphate concentration and replacement of phosphate when needed is recommended. A specialty high fat, low carbohydrate formulation is not recommended for ICU patients with respiratory failure. So, and again, there is no additional advantage of disease specific low carbohydrate and high fat over the standard or high protein or high energy oral nutrition supplement in stable COPD patients, not in ARDS and not in COPD. So they recommend mostly the standard or high energy, high protein formulation only. So the standard nutrition and acute kidney injury, the standard enteral formula is recommended for ICU patients with AKI. Protein should not be restricted in patients with renal insufficiency. Daily protein intake should be in the range of 1.2 to 1.7 gram per kg, actual body weight in AKI patients. Provision of adequate non-protein calories should be maintained to achieve total energy intake in patients with acute kidney injury. In case of significant electrolyte imbalance, a specialty formulation designed for renal failure should be considered. So low potassium and low phosphate diets can be implemented where corresponding serum levels are high. So we have to check more frequently for the electrolytes when we are especially dealing with the kidney patient. So finally, coming to the documentation of nutrition practices, which is again a very weak scenario in our ICUs. The documentation of body weight and its review on a weekly basis is recommended. The documentation of the below mentioned is also recommended. Screening and assessment tools used along with their scores and the weekly review scores. Nutritional diagnosis should be documented. Nutrition care plan on daily basis should be documented. And in any infectious complications and stool frequency on a daily basis. So this is a flow chart given by our ISCCM based on how to you have to proceed with the enteral feeding. And I'm just skipping over this and I will share in the group to have a better look of the entire flow chart. And this is a relatively easier one quoted by the Aspen guidelines to for the how to follow with the enteral nutrition and check for GRB and then what you have to do if it is the small bowel or the lower feeding intolerance. So if it's actually not getting absorbed or more diarrhea and all based on that you have to guide on your how to proceed with the enteral nutrition. So this is the 2022 update in Aspen guidelines. So they have talked specifically about the 5 points. The energy intake, protein intake, energy intake by parental nutrition versus enteral nutrition. Most of the time they have emphasized and they have spoke about the mixed oil ILEs, and FO means ILE refers to lipid emulsion and FO refers to fish oils. So all these things I will be sharing. I'm skipping this for a better discussion after the class. So to conclude, nutrition is now regarded as to be of therapeutic benefit and not just an adjunctive or support in improving patient outcomes. Early, optimum, and adequate nutrition helps improve patients' overall prognosis and at the same time reduce the length of stay. Enteral nutrition is preferable in majority of the cases. Scientific nutrition in the form of standard formula feeds should be preferred in majority of ICU patients over blend-raised feeds. In comparison to blend-raised feeds, the standard formula feeds have benefits of better feed hygiene, certain nutrient delivery, and lesser osmolarity and viscosity. Scientific nutrition intervention is very important to achieve better clinical outcomes. So not only you have to eat right, you also have to feed your patients right. And thank you so much for the patient hearing. And now we are open for discussion what are all we are practicing in our ICUs and all.
Thank you, Srikanth. Very well explained about all types of feeds in various conditions. It totally covered everything. Just now I'm taking a blenderized kitchen feeds while you are talking. Hope it is
Not contaminated.
not contaminated. So, can you mix both blenderized and commercial feeds?
Yes, that even that one is there. They have stated about when blenderized feeds are there. There are lots and lots of issues in this one. So which is why I briefly just touched at the end. It took pretty long time. So a standard feed scientific formula like the what one we are getting RTH, ensure RTH, and again a completely homemade preparation. And if you have an in-hospital kitchen, they can blenderize the naturally available foods. And that's another one is a mix and match of the standard formula with the into the blender. So all these things they have documented, but again when compared to standard formula, though in again the kitchen handling, and from there it comes to our ICU, the rate of infection complication, they say it's high with blend race. But again practically when we come down, so I've done a cost analysis of because we are trying to starting to implement in our ICU, so that he has quoted 500 ml of that Ensure RTH bottle of 905 rupees for the patient with a gravity set will cost 230 rupees, and it will be like in use for 2 days or like that. After 2 days or you have to again change the gravity set. So if you're going for a 100 ml second hourly initiation of 2 bottles, then 2, 3, 4 like that. We're giving on a full dose like that, 4 to 5 bottles are needed per day. That will be costing around 3,600 to 4,000 to the patient. So insurance cases and cash patients we can do again when we are coming to lower socioeconomic group. Again, in our scenario, it's a bit of difficult to.
Are you using daily the 3 to 4 bottles for all ICU patients?
No, sir. Actually, we are starting under Tepis Naminka, no. So we have to see. Current scenario depends. Currently, we are using that homemade, and that one only. We don't have a pantry in our hospital, so patients are bringing. So in order to reduce the infectious complications, we're planning to start this RTH in affordable patients. Any experience, sir? Anyone
Yeah,
using?
we have used RTH, mean 4 years or 5 years back, but we have not seen any change, improvement with RTH when compared to this commercial pits what sister is mixing at the bedside. But we have to take proper infection control precautions. There is no much difference, but I have observed that this RTH induces more hyperglycemia. But so many ICU consultants complain the same problem. We even complain to this about these people that
Now,
hyperglycemia is ultimately patient is developing hyperglycemia, even non-diabetic patients also.
yes, sir.
So
So
that
now they're
uh,
saying that the latest ones, what they are getting now, comes with no added sucrose based on the complaints received all over by the intensivist, is what they're saying. I have to see how it pans out.
Yeah. But tolerance is good when compared to this blenderized or feeds prepared by the nurse. But this RTH tolerance is better.
So one more question means more of a doubt, because you all are very much experienced. Have you used continuous RT feeds, sir? What subset
Yeah.
of population you're
Definitely.
using, Satish sir?
We are using for GI patients, and it is advised continuous feeds when patient is not tolerating well. Low dose continuous feeds. Satish is asking, Anna, please.
Yeah, actually we use gravity bags, continuous RT feeds, which is being given from our cafeteria as per our prescription. Okay, we have a very good experience with the continuous RT feeds. Almost we are supposed to feed 18 hours a day, but we have conducted a study over this. But most of the times we haven't met the criteria what we are writing as a prescription and what is actually patient is getting. Because usually we think that whatever we have written, it is going to the patient. But there is a lot of 60 to 70% even that is also not met. So if you write like 2000 kilocalories, 60 grams protein, normal electrolytes, diabetic diet at the rate of 50 ml per hour or for some 75 ml per hour for 18 hours a day from 6 to intermittently patient is subjected for an ultrasound, fasting is there. Patient must be shifted to MRI, 2 hours feeding is not there. Some procedure will be there, feeding may not be there. So ultimately, patient is not getting the enough time of 18 hours is not met. Second thing is, even though you write like there is 60 grams of protein, if you see the prescription, what actual dietitian is giving back to the patient will not be more than 42 or 45 grams of protein.
Yeah.
So this is one thing. Second thing is we were enthusiastic to write even 2 grams of protein, and we restrict the RT feeds to 100 ml per hour. So 2400 ml, and in that 6 hours is missed. So 1800 ml. In this 1800 ml to meet the 2 grams protein is very tough task because it becomes hyperosmolar fluid. So, and without our notice also, the sisters are spot enough. If the patient is having a little bit of like a diarrhea or something, they don't tell us, they stop the feed first. So unless you specifically look into the nutrition aspect of the patient, most of the things are missed. That's what my experience. Most of the things are missed. We assume that everything is going as per our prescription, but in between there are so many setbacks without our notice they happen.
Yeah, the main complaint of our patient attendants also, sisters are not giving feeding timely to my patient. How he will improve? So if you get 10 bottles or 12 bottles of feeds from the kitchen or preparation, 3-4 bottles are there without giving to the patient. So they are complaining.
Yeah.
You ask sisters, they said the patient has vomiting, or in between I am giving other medication. I'm looking after other patient. I told other sister to give the feeding. So like that. So as you said, almost 50% is missing.
Yeah. Second thing is I want to add, Dr. Chatan is there. Chatan.
Yeah, good morning, sir.
You better share your experience.
Yeah, so I just hearing about all this, that underfeeding and all that. So in our IC, we try to add intralipid 20%, especially a small lipid. As you know, because of underfeeding, some feeds are missed, and so this can be covered up by giving intralipids, where you can increase the caloric needs of the patient. So this is what we are giving for at least for a 3-4 days, so that the caloric deficiency, whatever is happening because of missing the feeds and procedure and shifting the patient, we can cover up with this. So we have experienced a good outcome in that, where we have able to wean the patient from the ventilators and all this. So that's why we are giving for few patients which can afford to intrapressure 20% intralipids. This is
With
what we
intralipid or SMOF cab even, the total TPN.
yeah, small 20%.
Intralipid.
Yeah.
Not TPN, total parental
No,
nutrition. With
not
SMOF
TPN,
cab
not
even.
TPN. Depending on the caloric requirement, we'll add a 20 to 50 ml or a 500 ml OD.
Okay, deficit you are covering.
Yeah.
And one more concept is partial parental nutrition, because as per the guidelines, what they say is, if we presume that this patient is not getting feed till 5th day or 7th day from now, better to start TPN as early as possible. But think our patients usually they will be fed even after day 3 or day 4, even if it is a gastrointestinal surgery. So, but thing is, prior to this, patient is already under malnutrition. Patient is in kept for NBM for the surgical point of view. So all these things add to the malnutrition of the patient. First thing. Second thing is, most of the times we presume that obese patients are overnutrition, but there is an obesity paradox. Even obesity patients also undernutrition. They have an undernutrition. So these are the points to be considered when you are trying to look into the guidelines, because guideline says that TPN is considered only if you think that the patient is not being orally fed for 7 days. After 7 days only we are going to. So it is not like that. We have to have a partial parental nutrition may be considered in Indian scenario, because most of the Indian scenario coming from the rural setup or somewhere, they're already under nutrition. On the top of that, now we maintain hospital sake decreased feeding, like fasting, investigations, because of the illness patient is not having feeds properly. So all these things add to the pre-procedural, pre-admission malnutrition.
Any questions from other centers? Rani madam?
Hello.
Madam.
What about like in severely hypoproteinemic patients? Like anyway, we are giving, like our hospital, we give some kitchen feeds and some formula feeds with high protein content and disease specific high protein things, and sometimes we also give aminoven or riomin or whatever it is, amino acids 10%, like to increase some protein part, because they're all malnourished and generalized edema, some of them. In those, are you giving what kind of protein supplements in addition to diet you are giving?
Yes, madam.
Srikanth,
Definitely.
David, Satish.
Yeah, we are giving, as you said, 10% amino acids, sometimes intralipids. A patient is not taking properly, we are not meeting the targets, we are giving 3-4 days, even TPN also. Depends on how patient is. Some people are tolerated very well, and nutrition is getting better. We are not giving, but some people are getting.
Polymeric feeds లో కూడా high protein feeds ఉన్నాయి సార్, ensure HP like that. Sir.
We give most of the time pentasure fiber, we advise, if no issue giving it.
We need to look into the formula feeds, where there is, like, most of the formula feeds each 100 grams contains 14 or 18 grams. But some feeds now they are coming with high protein. They say that 100 grams contains 38
25,
to
30, yeah, 30 grams, 30 to 40
grams of the one. My experience is there is Venki product is there. Venki product, it is giving high protein. Almost like 100 grams contains 40 grams of protein. So if that is the case, the consumption of total powder is less, which is very concentrated in high protein. So
what's that, Satish Garu? Is it a powder form in a tin or something?
Powder form, madam.
Inex HP also, it is high, 45 grams per 100 grams. Very high.
Okay. What is
HP? Inex HP.
Inex?
HINEX, Inex HP.
Okay. And maybe when is the role of peptides? Partially digested proteins are there in some. Some say that no, whey protein versus egg protein.
Yeah, we are using whenever patient having vomitings and abdominal distension. So this partially digested like peptamin, we are giving in that condition.
There are so many things are coming up now, but experience is very less. Like where to use, what is the purpose? Is it really meeting the criteria? Just for the sake of giving, or I don't know.
Good morning. A chronic patient who is dependent entirely on enteric feed, how frequently we have to change this rice tube, and how to manage the diarrhea while totally dependent on enteral feed.
Srikanth. Hello.
Increasing absorption ఏమేమి ఇస్తున్నారు డేవిడ్? ఎరిథ్రోమైసిన్ ఇంకా ఏమేమి
Erythromycin
ఇస్తున్నారు?
utilize madam, because IV erythromycin is not available in India. We are giving metoclopramide 10 milligrams IV BD. But all old patients, we are afraid of giving metoclopramide because of complications. So initially we
అది
start.
ఓల్డ్ పేషెంట్ మెటాక్లోప్రమైడ్ ఇట్స్ వరీయింగ్ ఎనీవే రెగ్యులర్ ఇవ్వటం. వాట్ అబౌట్ లెసురైడ్? డస్ ఇట్ వర్క్?
Lezuride, yeah, definitely we are giving, but I don't think it will work. We
Even
are
that,
giving. I don't think it works. Lezuride.
the problem with the Lezuride, most of the patients will land up into extrapyramidal symptoms.
మరి మెటాక్లోప్రమైడ్ కూడా సేమ్ కదా?
Lezuride also.
Lezuride also, yeah. Almost like Parkinson's behavior.
Okay. Erythromycin only IV ఇవ్వాలా? Can we not do oral?
No, IVA. No oral. Oral doesn't work. I asked the experts of Ravindra Reddy. It don't work. Better not to give if it is oral.
IV లేదా ప్రిపరేషన్?
మనకు లేదు, మనకు దొరకదు. One time we got from UK, from Muthinjay Rao, some anesthetist is there. His mother joined with abdominal distension and indigestion, all these things. We have used both metoclopramide IV 10 mg BD plus erythromycin 250 milligrams IV 6 hourly. It works very well and patient responded within 24 hours. And no complication.
David, here when you identify, where is the problem? Is it the gastroparesis or is it the intestinal?
Gastroparesis, sir.
Yeah.
Even after, because of diabetes and related gastroparesis, patient is motility problem, all these things. So it works well.
Yeah.
Unless after excluded all other possible.
That's, we have to classify and identify whether it is gastroparesis or paresis or large paresis. If it is a large intestine, maybe a neostigmine works there. If it is a small intestine, something perinormal
like pseudo obstruction,
erythromycin works.
What about like gastric aspiration? Like, are you all doing on regular basis or in hours ki or shift koksara, day koksara? How often are you doing?
ఒకసారి చేస్తున్నాం మేడం మేము. ఒకసారి aspirate చేస్తున్నాం. అది as Srikanth said, if it is more than 300 to 500, more than 500 we are keeping NVM, and between 300 500 we are not giving back to the patient, but we are reducing the quantity, means 50 ml second hourly, like that. If it is more than 500, we are withholding the feeds and giving gastro referral.
That 500 ఎంత time లో 500 in a day na 500 in a shift?
When we are aspirating for the GRV, madam, so most of the guidelines they suggest 4th hourly or 6th hourly, madam.
అదే కరెక్ట్. 500 ml in
500 ml
hours.
when we are aspirating that, I mean like about 4 hours or 6 hours into that, when we are aspirating.
Actually, guidelines says there is no specific timing to aspirate. Whenever you have a doubt, aspirate. If it is more than 500 ml, stop feed. If it is less than 500 ml, just reintroduce the feed. But it is not that maybe sometimes, no, example wise, if I give 50 ml per hour, if I give 50 ml per hour, after 5 hours, it is 250 ml. If I give 100 ml per hour, after 5 hours, it's 500 ml. So we don't consider that whatever the that is how much amount we are giving, how much hours, how many hours we are giving. Only thing is, if you have a doubt, aspirate and find out the quantity. More than 500, stop it. Less than 500, 300 to 500, reintroduce it. Less than 300, don't change.
Now, one problem with if you have a doubt, these patients shifted to ward with RT feeds. That sister don't have any doubts. She keep on giving feeds. Suddenly, patient had big vomiting, very big vomiting with a lot of feeds, and he aspirated and collapsed in the ward. These things happened in the wards sometimes.
Yes.
So
See, that's
what we did, every shift we advise them to aspirate with syringe only, because
Yeah.
they don't have any doubt, no.
Yeah,
Even
understood.
organ burst also they don't have any doubt.
That is the case. This volume may not work there because I am giving 100 ml per hour, and after 5 hours, there is a possibility I will get all the 500 ml back.
Patients you are giving continuous feeds.
Yes.
All patients.
All patients in ICU who are on rails tube.
Through syringe pump. I mean infusion pumps.
No, through gravity bag.
But will it meet the gravity bags your targets?
That's what I'm
Sometimes,
telling. See, if it's gently followed, we can meet. But we depend on sisters and they don't bother about it.
that's what they will open, and sometimes it blocks, it won't go, so they don't see. And again the problem. If you have an infusion pump, it meets.
Yes.
Yeah, 100%.
More, Sanand, we haven't completed his question. We haven't answered. How frequently we change the rail tube? Somebody asked this.
How frequently change the rail tube?
Yeah, the one question is posted here. How frequently which you should change? There is no point in timing. There is nothing like these many days rail tube can be continued unless otherwise it is like discolored or color change happened and the tensile strength is changed. All these things consider and change it. There is no periodical changing of the rail tube. And if you feel that patient requires long-term feeding, better to keep the patient on free cut tube.
Yes. Another question: possibility of refeeding syndrome after starting TPN.
Yes.
Very.
Very.
Yeah. Cheppanna, refeeding syndrome.
Yeah, it is to be considered. It's a point to be considered whenever the patient is started on TPN. We need to have a basal electrolyte situation of the patient, like check the magnesium, phosphorus, all the electrolytes, and periodically follow up the phosphorus. If you find this patient is having a hypophosphatemia after restart of the feeds, better to supplement the phosphorus and consider the point of refeeding syndrome.
What type of phosphorus you are giving? Is it potassium and phosphate?
Phosphate is there. Yes.
Is there? You are giving that?
Adphos tablets are there. Adphos tablets are there.
If you have to correct both potassium, then you give phosphorus. Otherwise, just
Adphos.
phosphate.
Yeah.
What about phosphate enema? Will it work?
It's indigenous jugaad. Because we don't have anything available, just use the phosphate enema into the rail tube. That's all. But there is no guidelines. And it is, I don't know validity for that also.
What is the dose?
Arbitrary, 10 to 5 ml TID.
Okay. So after checking the phosphorus levels.
Yes.
Sir, Adphos tablets, sir.
Yes. Yes.
Tablets.
Has anybody used magnesium orate?
Madam, magnesium? IV. Hello?
Okay.
Madam?
Any of you used magnesium orate?
Magnesium orate?
No.
New product actually, it has more magnesium content than other magnesium. supplements.
Oral?
Yeah, particularly in refeeding syndrome and all that, it's very useful, I believe. We have its availability, but we haven't used yet. That's why I'm asking anybody used it.
Actually, we are using this stone 1 syrup, which contains potassium and magnesium combination. So depends on the potassium levels and even magnesium normal also we are giving this syrup stone 1 for hypokalemia. We are not giving separate magnesium syrup. Hello? Now, if there are no questions, we will conclude the session.
Sir, how to put a silicon rice tube similar as a usual rice tube or
Silicon, sir, Freca tube. Freca tube kada?
the silicon rice tube annaru?
Silicon rice tube to reduce the infection. Same how routinely you are using your rice tube. Because like police catheter, silicon police, infection chances are less. To keep for more days. So,
after putting that, is it necessary to confirm by radiograph or not?
Same, yeah, same. Routine practice. We have to confirm by radiograph. Definitely.
So it will go on to
using ultrasound. Ultrasound we are using to confirm. So we are not taking X-ray for every rice tube.
Actually, on paper they will ask for actually abdominal X-rays. చాలా సార్ మన చెస్ట్ ఎక్స్రే తోనే కొంచెం కిందకి తీసుకెళ్తాం.
Abdominal X-ray తీయాలి ఎందుకంటే మన సరి కనబడదు చాలాసార్లు చెస్ట్ ఎక్స్రేలో. We will confirm by auscultation and okay.
Not a recommended procedure.
But very rarely.
But most commonly used is, but కొన్నిసార్లు మిస్లీడింగ్ ఉంటుంది బాగా లంగ్స్ కూడా బ్యాడ్ గా ఉన్నప్పుడు ఆ సౌండ్స్ అవి కన్ఫ్యూజ్ అయిపోతాయి.
Stroke CVA patients lo, that must be very careful that easily it go into the lungs, and patient also it won't have any cough, any simply accept the food and patient suddenly desaturate. It happens.
Also they say that the presence of an ET tube doesn't exclude your Rayleigh tube going into the lungs.
Yeah, it may go along with
common with
all the old traditional things will not work. Because those days it is not available and it is difficult to done. So we have to follow the guidelines. So otherwise tomorrow we are answerable to the legally. So thank you very much, Srikanth. Very good presentation. Please share your presentation in the group.
Sure, sir. Sure.
Thank you all audience for your active participation. Thank you.
Thank you all. We'll meet you on Saturday.
Thank you, Srikanth. Bye.
Thank you.